Welcome, everyone. We're glad you're here tonight. Thank you for taking time out of your evening and your day. We appreciate it very much. I'm Robert Weldon, the National Sales Director for Cell Science Systems here in Deerfield Beach, Florida. And we welcome you to our monthly webinar series with our great clinical Director of Education, Dr. Ronald Grabowski. And well, I don't know where I got Greenberg at. Anyway, we're glad you made it tonight. We have a really good presentation tonight, of course, on a topic that affects every practitioner. Every practitioner sees patients with diabetes or about to be diabetic. And tonight's going to be a really good presentation on how to tie in the nutritional deficiencies with diabetes that affect diabetes. And just a little housekeeping before we really get cranking here. Of course, many of you already know that we've been in business since the 80s. We're not a new lab. Cell Science System is the leader in macro and micronutrient testing. We also do telomere. We do SICA, which is celiac, IBS, and Crohn's testing array. And we do methyl detox. And soon, just to give you a little teaser, we have a brand new test that we think is going to be very beneficial in your practices and with your patients called Inflammaging. And I know many of you have already seen the presentation by our CEO, Roger Deutsch. He's presented that a couple of times. Hopefully you've seen that presentation, and there'll be more coming in the near future. Many of you already know Dr. Grabowski. He is a leader in this industry with nutrition. He's an RD, a DC, but he's also a researcher and a clinician who is still in practice, even though he does many, many speaking events. So you're getting the best of both worlds. You're getting someone with over 30 years of experience in clinical nutrition. And of course, he's an expert in micronutrient testing. He's used that since way back in the 90s, before many people even knew what that was. So we're glad to have him on our team. I know everybody respects him, have maybe heard him speak before. He's a very good educator, and he shows you how to use testing in your practice, not just to look at the data, but also how to diagnose and treat your patients. So without any further ado, we will have some Q&A at the end, and we'd like to just turn this right over to Dr. Grabowski. Dr. Grabowski, it's all yours.
All right, thank you, Robert. I appreciate that. And like Robert said, this is a condition that affects every one of us in our practice. And you can see here from these statistics that this particular condition, diabetes, is increasing in numbers on a decade basis. And it's really interesting that we find out how this particular condition affects other particular conditions. And this is very important to see this evening. Really, one of the main things that I want to achieve with all of you tonight is to show you the comorbidities associated with this condition and how medications that are used for this condition or other conditions can actually tie in to the nutritional deficiencies that we look at. One of the things that we see on a regular basis is individuals that come to us with this condition, and of course they have high blood pressure, they have high cholesterol or triglyceride levels, or they may have neuropathies and all that. And of course we all get caught in these tunnel where we look down this tunnel and say, okay, it must be B12 deficiency or it must be B6 deficiency. Well, I'm going to show you why certain medications are causing some of these signs and symptoms, but more importantly is how we can prevent some of the comorbidities associated with this and how they've changed really in the last decade or so in regards to importance. Okay, so you can see here that approximately 40%, on the average, 40% of people that have this condition do not meet their target control in regards to glucose, triglyceride or cholesterol control, or blood pressure that's associated with this. And we know that there's several medications and how they work. Some affect the pancreas, some affect the way our carbohydrates are absorbed from our GI tract, some affect the way that glycogenolysis is involved in how we release glucose from the liver into the bloodstream, and once again, how we affect certain receptors on our particular tissues. Okay, so you can see we all know that there's two types of diabetes. Well, there's actually three types. The third type is when people talk about Alzheimer's, they now call Alzheimer's type 3 diabetes. And probably all of you know that. So, but when we talk about diabetes mellitus by itself, there's two types, type 1 and type 2. And as you can see here, 90 to 95% of all people that have this condition are type 2. And why this is important is because we talk about this condition as insulin resistance. Well, I'm going to show you how nutritional status affects that. And even if a person has type 1, how micronutrient intervention can actually assist you in treating the type 1 diabetic. And if the type 2 diabetic does not more or less result from an inflammatory condition or an infection or something like this, does it more or less result from a nutritional deficiency? And I'm going to show you how that can occur when people avoid certain foods or people have certain medications that can lead them to diabetes. The other thing that's really important about this is to see what we can do to decrease the severity or the advancements of these comorbidities. Okay. So when we look at the population, as I mentioned, only 5 to 10% of our diabetics are type 1, which of course we all know require insulin. And a lot of times I'll hear from patients, they'll say, well, my doctor says that I'm going to require insulin the rest of my life, so there's really, not much that nutrition can assist with. Well, that's not true, because once again, even though if the pancreas is not functioning and you're taking insulin, you still have to look at the insulin receptors. And you also have to look at the way certain items are taken up in the GI tract, and also, once again, how the liver modulates the glucose. And so by taking that into consideration, it's very important that we address the nutritional aspect, not just the macronutrients like carbohydrates, proteins, and fats, but once again, the micronutrients. And of course, there's a lot more information than I have time to discuss here in regards to all the nutrients that are involved or have been associated with diabetes, but I picked out the major ones that I really want to emphasize tonight. Okay, so when we look at this, there's a new staging classification of type 1 diabetes, and you can see these are the 4 stages. I'm not going to read these to you. Of course, you have these slides available to you in the future, but the point is that when we are looking at a diabetic, we have to realize that there is certain stages that they're going through. And are we catching these stages at the early spot? Or are we waiting to them to get to the point where it is an absolute necessary that they take insulin? Once again, we see a lot of patients today that are type 2 that started out with oral medications and then they've advanced to insulin, or they take a combination of insulin and some of the oral medications. And once again, this is why we have to address these. And there's certain things that, once again, cause these things to occur. Okay, so when we talk about type 1 diabetes, and if you want to hit the next one, of course, a lot of us think about genetic cause, and that's true. We also have to look at immunology. And one of the things we're seeing today is where people are getting sick, particularly with viruses, whether it's COVID, whether it's flu, or with some other type of virus, and those viruses have a tendency to attack the beta cells. When they attack the beta cells, of course, if they damage enough of the beta cells that make the insulin, then of course the person may go into type 1 diabetes. And of course, do they have some other reason that's causing insulin deficiency? I'm not showing you any case studies tonight, but in the future, I will show you some case studies regarding the cell science, micronutrient test, and various conditions. But I do want to emphasize this, that I have a young individual right now as a patient. He's 12 years old. He's going through some family problems, and his father and mother are going through a pretty intense divorce, and they're stressing this kid out. 2 months after this kid found out that the parents were going through a divorce, he developed type 1 diabetes. And this has been confirmed by endocrinologists, and he's on insulin right now, and the parents brought him to me. the important point of this is, and you'll see when I talk about some of these micronutrients, is 2 major micronutrients were severely deficient when I first saw this kid. And this was only after about 2 months of the onset of type 1 diabetes. And so we often talk about the treatment, but what can we do to prevent this condition that's accelerating around the world? Next. And so, you know, when we look at these individuals of type 1, we usually think, of course, these individuals are lean, of course, they've had recent weight loss, and then of course, we always talk about the 3 Ps. On the other hand, when we talk about type 2 diabetes, of course, we always think about obesity. The person usually is obese, but that's not always true. I have a lot of thin individuals, in fact, a lot of athletes, your CrossFit, your marathoners, your individuals that exercise 4 or 5 times a week that have developed diabetes and have like 5, 6, 7% body fat. You say, well, how can a lean individual like that go and develop diabetes? And I'm going to talk about that when we get to the micronutrients. Okay. So when we talk about, of course, this condition, one of the things that's often talked about is small vessel disease. Of course, we know that we, affect the eyes, we affect various organs, which we're going to talk about here in a second. Then, of course, it can get into the larger vessels. And of course, we also know that if a person has diabetes, that they're more susceptible to infection. I'm going to show you why that happens. It's not just a vascular relationship that comes into play. And of course, then whether or not the person's taking insulin, if they take too much insulin or not enough insulin or so on. Okay, so the big thing that we look at when we talk about the small vessels disease, and you usually see this on advertisement, and a lot of pharmaceutical companies today are talking about if you have diabetes and you don't control it, you have a higher incidence of coronary artery disease. And that's true. Next, and if you see this, you can see that if you have diabetes, yes, you have a 4-fold chance of having coronary artery disease. But if you look at the top of this, you see that blindness is a 25-fold increase. Renal disease is 17-fold increase. And of course, gangrene or loss of a limb is 5-fold. So the importance is, yes, heart disease is increased when we have diabetes, but the blindness and the renal failure is much higher. So I always tell my patients that have diabetes, if I can protect your eyes and I can protect your kidneys, I know I'm going to protect your extremities and I know I'm going to protect your heart, because it all comes into play. And you'll see this in the next slides that we're going to. Okay. So once again, you can see that several people a year develop blindness as a result of diabetes. And of course, this is why we encourage our diabetics to go to the optometrist or ophthalmologist on an annual basis. And these are, of course, the views of showing the diabetic retinopathy and also the macular degeneration, the difference between, of course, and the normal eye. And I'm going to show you how nutritional support through certain micronutrients will help delay these processes from occurring. Okay. So in the past, if you look to your left, the blue, the kidney disease, the retinopathy, the peripheral neuropathy, that section is what the old thought process was, and those are the comorbidities that everybody associated with diabetes and still looked at. But the newer complications associated with diabetes are to the right: the cancer, the infections, the liver failure. And then, of course, as we go into that, we go into functional disability, we have cognitive problems, and various other disorders. So the point is, we've advanced, we're finding out that there's a bigger connection now with some more serious conditions like cancer and liver failure when a person does not control their diabetes. And that's why I mentioned earlier that Alzheimer's is now called type 3 diabetes. So if a person has diabetes and they do not control it, they're going down that road to Alzheimer's or dementia. And that's something I think that's very important to emphasize to your patients, because, when diabetics come to me for the first time, I say, well, what do you know about diabetes? They go, well, yeah, if I don't balance my blood sugar, I might have a heart attack. I said, yeah, but then I mentioned Alzheimer's, I mentioned cancer. And they go, well, I didn't know that. And as soon as I mentioned those more serious disorders, it seems to really open their eyes on they better control their glucose levels and their A1C. Okay, so here's some pathogenesis of more or less the complications associated with diabetes. And it's a very detailed schematic. And you can see here, this was published recently in 2019. And we're going to talk about these from a micronutrient standpoint. We're going to talk about free radical production. We're going to talk about inflammation. We're going to talk about certain vitamin and mineral deficiencies. And once again, we're going to talk about medications as well. So the big thing to really emphasize on this particular slide is how we get to these comorbidities from a poor regulation of a diabetic. And can we, once again, prevent some of these comorbidities and also medications that may be pushing us into diabetes? Next. So here's a schematic showing you that we have inflammation as a major player, not just in type 1 diabetes, but also type 2 diabetes. And you can see some of these inflammatory markers like tumor necrosis factor alpha, interleukin 6, the involvement of the natural killer cells, and how this comes to the point of damaging the pancreatic islet cells. And if that occurs once again, and we damage enough of them, of course, then we go into the type 1 diabetes. And once again, so a person starts out at type 2, and eventually they can go into insulin dependency. And once again, if it's severe enough as far as the pancreatic damage, they will always be insulin dependent. However, once again, I want to emphasize, we still have a major role to play with micronutrient intervention with the type 1 diabetic. Even though it only makes up 5 to 10% of the population, we want to, of course, address the type 2 because, of course, the larger percentage. Okay. So when we look at type 2 diabetes, the same thing occurs. Inflammation comes into play, oxidative stress. For example, how can we develop diabetes if we exercise on a regular basis? And this goes to the point what I mentioned earlier, that I have some CrossFit, I have some marathoners, I have some triathletes that have developed diabetes. And say, well, how can you develop diabetes? Because isn't exercise good to prevent diabetes? It is, if we don't develop so many free radicals that cause damage to our tissues. And how do we quench those free radicals to prevent that damage? And once again, it comes down to our antioxidants. And so you're going to see this evening how certain vitamins, certain minerals have those roles. And this is why if a person is exercising to so-called stay healthy, how the importance of the micronutrient status is important. And you can't, as we all know, you can't just look at somebody and say, oh yeah, I think you're low in vitamin D, or I think you're low in magnesium. We need to do some objective testing to determine what nutrient or nutrients are low to cause that. Okay. So once again, when we're looking at this, this is a schematic, once again, of showing you, going back to that previous slide where I showed you, if a person has diabetes, it may go to liver dysfunction. If a person has, once again, excess exercise where they're developing free radicals and they're damaging muscle tissue, it can cause inflammation and eventually cause diabetes. If a person is overweight, if a person has a bad microbiome, if a person has digestive problems, and they are not addressing those digestive problems, can those digestive problems eventually lead us to diabetes? Absolutely. And so this is why it's real important that we, even though we're talking about diabetes, that we look at other systems in activity and to determine if this is really the cause. And this is why when people come to you and they're so-called healthy and they say, you know, I exercise 4 or 5 times a week, I think I eat healthy, and I want to make sure that, you know, I don't develop heart disease, I don't develop diabetes, I don't develop thyroid problems, or whatever the case is that we address certain nutrients that are in the literature that are very supportive of decreasing our free radicals or supporting our insulin receptors or supporting our pancreatic tissue to allow us to make insulin, to also secrete insulin, and of course, also affect the insulin receptors when the insulin's made. Okay, so here's a situation. Well, what about these individuals that we see that aren't diabetic yet? So they're not running a 140 glucose on a regular basis. You know, maybe instead of a 5.7 A1C, they run a 5.8 or 5.9. Do we have to worry about those, or should we address those? Yes, you know, a lot of times I see those people in my clinic, and the doctor says, I'm pre-diabetic, okay? And what we really know, what the doctor's trying to tell that patient that's in our office now, is they're hyperglycemic. Well, hyperglycemia, as you can see, leads through these pathways and eventually causes oxidative stress. And when we have that oxidative stress, now we start to damage more tissue. So a simple thing where a patient says, well, yeah, I'm only running a glucose of 105 or 110. Do I really need to be concerned? Yes, they need to be concerned, because that particular status is leading them down the road. But what is causing that elevated glucose? Is it really obesity? Once again, it doesn't have to be. As I mentioned, it could be overexercise. It could be medication, which we're going to talk about tonight. And some of the medication that's used to treat diabetes can be causing some problems. So next. So when we are looking at this, you can see one of the major concerns today with diabetes is kidney failure. And you can see here where that hyperglycemia leads to the advanced glycation of proteins. It leads to oxidative stress. Of course, we affect the vascular system. We have these other factors that are causing this pro-inflammatory state. And then, of course, we look at coagulation. But whatever the case is, and the point is, can we slow down or can we increase the GFR of these patients if they're in stage 3 or stage 2 of renal disease? Absolutely. I see it all the time where people come in, they have elevated creatinine levels, they have abnormal GFRs, and of course we know that they're having kidney involvement. And if you address certain things, certain micronutrients, can we get their kidneys to function efficiently or to the point where they're not going into dialysis? Because we know that once they hit dialysis, that it's a very, very complicated situation, and it's very demanding. We all know that. We've all been around those individuals, and the point is we need to keep them from that situation. Okay, so when we are looking at this, you can see once again that we have this hyperglycemia. It's going through these stages, and then this is more or less showing you the vascular complications of this particular status. So once again, we go into damage of the vessels, we go into abnormal metabolism, we go into inflammatory states, we increase the permeability of certain vascular tissues. And of course, we can measure these inflammatory factors. And once again, we know that the more weight that a person has, that additional adipose tissue that they have, it's going to be more inflammatory. So yes, we know that inflammation is there, but once again, we also know that inflammation isn't the only cause of type 2 diabetes. And we know it's not just weight, as I mentioned earlier. Okay. So when we're looking at this, one of the first nutrients I want to talk about is magnesium. And if you go through the literature, and you can see this was published recently in the Journal of Nutrients, which is an excellent journal, by the way, if you're looking for a journal to follow. There's so many journals out there that you could follow, but this is definitely a very comprehensive journal. It hits a lot of different subjects regarding to nutrition. And you can see here, if we go down 3 or 4 steps, you can see that insulin resistance / type 2 diabetes is associated with magnesium deficiency. We know that. So we know these other conditions are also, look at the very bottom, cancer. Well, we also talked about diabetes is associated with cancer, right? I also mentioned that Alzheimer's is associated with diabetes. And here magnesium deficiency is associated with Alzheimer's. Cardiovascular disease, I mentioned, is associated with diabetes. And isn't it interesting that cardiovascular disease is also associated with magnesium deficiency? So you can see how when people talk about these comorbidities associated with diabetes, is there something we can do from a micronutrient standpoint to resolve or lessen the effect of these other comorbidities? Okay, so when we're looking at these, These are some of the common or known signs and symptoms of magnesium deficiency. And I want to take you down to the middle of this particular slide where it talks about metabolism. You can see pancreatic beta cell dysfunctions associated with that, insulin resistance, of course, decreased glucose tolerance, increased risk of course, metabolic syndrome. We have abnormal lipids, of course. We have effect on vitamin D status. The point is that several things that we see with a diabetic are associated with this particular mineral deficiency. So let's go out here with a patient that's starting to gain some weight. They don't have diabetes yet. They don't even have abnormal glucose levels. But one of the things that they do have is high blood pressure. They're starting to develop an abnormal blood pressure. So they go to the doctor. They get prescribed, of course, an antihypertensive medication. Well, say it's a diuretic, which of course is very common medication for high blood pressure. Well, say that diuretic causes magnesium deficiency, and say that patient is on that diuretic for 2-3 years. And all of a sudden, isn't it interesting that the patient now is going to the same doctor, getting this antihypertensive medication, and now this doctor says, oh, by the way, you're pre-diabetic. Your glucose is starting to go up. And so if the doctor doesn't put the antihypertensive medication in connection with possibly magnesium deficiency, now the patient may go on metformin. And so now they're on 2 drugs. They're on an antihypertensive medication and they're on metformin. But wait a minute, that antihypertensive medication, that diuretic, caused magnesium deficiency. And the literature right here, you can see, shows that if you are magnesium deficient, you have an increased chance of glucose abnormalities at several different phases: beta cell dysfunction, glucose intolerance, metabolic syndrome, abnormal lipids. And now you have abnormal lipids, so of course you have antihypertensive medication, metformin, and by chance now you might be put on a statin, and we're going to talk about a statin and how that particular medication may also come into play with glucose regulation. Okay, so now we're going to talk and show you some schematics and some different things, and this is very involved as far as the different mechanisms, but the point is a simple mineral like this on how it can prevent us from going from a simple status of a normal individual from a not hypertensive, not diabetic, not osteoporotic into this, and I'm going to show you how that happens. Okay, so you can see here, and this was published recently in 2019, you can see that if you decrease the magnesium intake or if you have increased magnesium loss, I'm going to talk about how that happens besides the medication I mentioned. It could be some genetics involved, of course, we always know that, and of course, as I mentioned, early medication. One of the major players that causes magnesium deficiency is something that we face maybe not every day, but at least every week, is stress. Psychological stress or physical stress, and this is well known, causes increased loss of magnesium. And this is why you often hear patients say, man, you know, I've never had elevated cholesterol, I've never had elevated glucose until I took that managerial job, or until I was promoted this, or until I started working this other job. Or, you know, now a family member is sick, and so now I'm under more stress, or my traveling time is more stressful. Just that simple word stress can cause magnesium loss. And this is why we start to see people elevate their blood pressure, elevate their glucose levels, you know, have other things like headaches, have GI problems, and so on. And so a simple mineral like magnesium, as you can see through this schematic, and they did a wonderful job in this journal showing this, leads to kidney problems, leads to diabetes, leads to cardiovascular, leads to neurological complications. I tell patients this all the time, and I'm telling you as clinician to clinician, if there's only one nutrient that I could carry in my office, this would be the nutrient. And because it has so many relationships with other functions and diseases. Okay, so the importance is that we try to address these before it happens. And here's a study showing you, a Canadian study published in 2017, showed that people that had diabetes had lower serum magnesium levels. Now we know that if this is the case, they definitely have lower intracellular levels because serum magnesium is not even a sensitive marker. For serum magnesium to be low, you have to be significantly low. This is way down the road. So we want to catch it before we get to the serum magnesium levels that are depleted. And how do we do that? We look at intracellular levels. I mean, there's studies out there showing that looking at the lymphocyte magnesium is going to be much more sensitive than looking at serum levels. But they found that there was a relationship with serum. So once again, this is the purpose of testing and getting objective data and the old word prevention. How do we prevent some of these conditions? Why is diabetes keep rising on a decade basis? Okay, so here we are. What are some of the relationships of magnesium? We talked about magnesium being, magnesium deficiency being caused by stress. We talked about medications that can cause magnesium. Well, why is it so important from a prevention of diabetes? And once again, these are some of the roles that magnesium plays. The other thing is, of course, as I mentioned, there's a connection with magnesium and vitamin D, and we'll talk about that later this evening. But the point is, you can see there's some substantial reasons why magnesium status is important. And it's one of the more common ones affected today. And I talked about those athletes. I talked about the CrossFit. I talked about the marathoners. Once again, that is physical stress. There's psychological stress, there's physical stress, and there's oxidative stress. Okay. So as I mentioned, one of the concerns with diabetes today is liver dysfunction, liver disease. We talked about the retinopathies earlier. We talked about, of course, the gangrene. We talked about the neuropathies and things like that. And we've known that for years. And those things were important. We were always looking at those. And now, like I said, it's advanced to some of the more serious conditions. Well, look at this. Isn't this interesting that magnesium deficiency also has a role to play with liver disease? So here we are. We have a condition, diabetes, that might have been caused by magnesium deficiency or may not have been caused by magnesium deficiency, but as a person has diabetes now, and we know this for a fact, that as glucose levels fluctuate, going from, of course, a normal state to an elevated state, we urinate out and we excrete more magnesium. So the more often that a diabetic does not control their diabetes, the better chance they have a magnesium deficiency. And the more they have magnesium deficiency, now they go from diabetic to now they have cardiovascular disease, now they have liver disease, now they possibly have cancer and so on. All right. So once again, what about obesity? How is magnesium maybe connected to obesity? You can see here that decreased magnesium levels increase inflammation. What does chronic inflammation do? It's stress, right? It's oxidative stress on our body. And as you can see, things like tumor necrosis factor alpha and interleukin 6, which I showed you on a previous slide, some of the inflammatory markers, these particular markers go up. And as they go up, our magnesium levels continue to be affected. And once again, we have shown that if we increase our magnesium levels, we have a better body mass index, we have a better lipid control, we have a better glucose control, and we also have less inflammation. So you can see that it's more or less a dog chasing his tail, that if you don't correct the deficiency, and say a person is just taking medications for their diabetes, they are going to go from maybe an oral medication to now insulin dependent. And they're going to have some other comorbidities associated with it. But of course, I hear this all the time from my patients. Oh yeah, my doctor says, of course I have neuropathy, I'm diabetic. But could that neuropathy have been prevented or could have been lessened if they also looked at the micronutrients? And I'm going to show you absolutely it can be. Like I said, I'm not going to be able to cover all the nutrients tonight, but I'm going to cover some major ones. Okay. So once again, when we look at this, you can see that decreased magnesium levels, once again, are caused by various things. As I mentioned, the diuretics. So if a person's on a diuretic. Now, I'm not even talking about prescription diuretics right now. I mean, I did, but what's another diuretic? Alcohol is a diuretic, right? caffeine is a diuretic. So say a person consumes a lot of caffeine in their daily diet. Say a person says, oh yeah, I drink a couple glasses of wine every night because I hear that wine's good for the cardiovascular system, but it's also a diuretic. And because of that, it's going to cause magnesium deficiencies. And so, I always used to kind of chuckle when I would walk into a patient's room in the hospital. And of course, when I would be talking to the patient that was diabetic, I'd say, well, what do you drink? I mean, do you drink water? Do you drink juice? What do you drink? Oh, no, my doctor says I can drink as much coffee as I want as long as I don't put sugar in it. I'm thinking, okay, no, that's not true, because the reason we know it's not true is because caffeine is a diuretic and caffeine will cause magnesium loss. And if you are drinking black coffee as a diabetic, you're going to increase this mineral loss and you're going to have more, problems with regulation of your glucose. Okay, next. So the point is that we know these comorbidities associated with it, with diabetes, are common, but do we really know that there's certain nutrients that are also common with these morbidities, these comorbidities? And so once again, it's coming back to the point of this is just one nutrient, and you're going to see there's some other nutrients that we're going to talk about that do this. And so once again, here goes back to the point of, yes, if you are diabetic, you have a higher chance of cardiovascular disease. But why is that? This is one of the minerals deficiencies, why that happens. Okay. So as I mentioned, a lot of people that have diabetes go down that road and eventually have kidney disease and or kidney failure where they develop diabetes. I worked in dialysis as a dietitian for a few years, and I can tell you the majority of my dialysis patients were diabetics. And the sad thing is I also worked in endocrinology in the hospital, and I knew that those diabetics, if they didn't control their glucose, that they were going to be going in dialysis that year or next year, a couple years down the road. And we all know that's a very, very serious disease. Okay. So the point is there something that we can do to maybe slow down that destruction of the kidney? And can we preserve the kidneys to the point that they don't go on the dialysis? I don't know the exact statistics now, but I know a few years ago that it was like 8 to 10 year waiting list for a kidney transplant, unless you, of course, had a family member that was a perfect match. Well, I don't know about you, but I don't want to be going to dialysis 3 times a week for at least the next 8 to 10 years if I'm a diabetic. And working around diabetics or being around dialysis, it's a horrible and a very demanding process doing that. And of course, their traveling capabilities, their enjoyment of other things in life are severely inhibited because of that dialysis. And so we don't want that. So once again, in the literature, okay, that we looked at, we have found that there is definitely some protective effects of CoQ10 on the kidney, whether it's an acute situation, meaning that person had some injury or some medication that might have been, say, the person was taking ibuprofen and they started to see some damage to the kidney. Could CoQ10 possibly help that? Yes. Okay. Once again, person getting diabetes and we start watching the GFR, watching the creatinine levels. Can we catch that? And here's a great schematic you can see in the Journal of Antioxidants in 2020 that was published, showing you the various systems of the body that are benefited by CoQ10. The interesting thing, and we'll talk about this a little later, and all of you know this, is CoQ10 deficiency is very common when a person takes a statin. Well, once again, remember what we've all heard? If you're diabetic, you have a higher chance of cardiovascular disease. You have a higher chance of cholesterol problems. But if you have a higher chance of cholesterol problems, guess what you're probably going to be prescribed is a statin. For those of you doctors that are prescribing statins and you want to protect the kidneys on these individuals and protect their nerves and other parts of the body, other systems, this is a nutrient they need to be on. And this is one we check for. Okay, and once again, we can check the level and see if 100 milligrams or 200 milligrams or whatever level is adequate. We don't want to just assume that 100 milligrams is going to do it because we don't know. Everybody's different. Okay, so the point is that, whoop,
Sorry.
that's okay. The point is that this particular nutrient is highly vulnerable to a deficiency because of 1, diabetes, 2, medications. But this is another interesting thing that I want you to think about, is when we exercise, our demand for CoQ10 goes up. So think about what I'm saying. If we require more ATP to maintain our exercise regimen, and we're not taking in enough CoQ10 products, or we're not producing it because we can produce this nutrient, and our production goes down, or it's not meeting our demands, guess what? We can start to have kidney problems, we can start to have heart problems, we can start to have these other problems. And you can see here, based on this information, that they have shown that higher serum CoQ10 levels, once again, are associated with lower A1C levels. And of course, that's what all of us want to monitor, right? When we monitor the diabetic, we aren't looking at serum glucose levels, we're looking at A1C. Okay, so the point is that these factors that we're monitoring, or we look at to see where our diabetics are going, or even our pre-diabetics are going, can be affected by this nutrient. And if they start out with high cholesterol and they're put on a statin and their CoQ10 starts to drop, now we may start to see glucose problems. So once again, this is very important, okay, to look at this. Now, once again, as I mentioned, one of the major organs affected with diabetes is the kidney. And you can see here, we found that CoQ10 can be preventative, and I've seen it in my clinic, can actually improve a person's kidney function. I've seen it through GFRs, I've seen it through creatinine levels, it's in the literature, but once again, we have to make sure that the level is adequate. And when I say level, the dosage we give them is adequate. And once again, most adults will start out with 100 milligrams. And once again, we'll talk about that in a second, because if we give too much CoQ10, it can actually cause some deficiencies like carnitine, and carnitine deficiency has been associated with end-stage renal disease, which also has been associated with cardiovascular disease and can cause some problems as well. Okay, so the point is, another thing that we look at, as I mentioned in the past, and we still talk about it today. In fact, I saw a diabetic this morning, and she has neuropathy, and she's on no nutrients. I mean, no vitamins, no minerals, nothing like CoQ10. And isn't it interesting that she's on antihypertensive medication? She's also on a statin. And I sent her out for blood work today. I sent her out for, once again, a cell science intracellular nutrient test, the CMA, and said, look, I will be very, very surprised if you're not CoQ10 deficient. I'll be very surprised if you're not vitamin D deficient or K2 deficient. And there's some correlations why. And you can see how important that is. And once again, she was told, well, my doctor checked my serum B12 and he told me that my neuropathy is not nutritionally related because my serum B12 was normal. Well, doctors, if you're listening and that's what you're telling your patients, you're not telling them the full aspect of what's causing neuropathy. I have a whole lecture on neuropathy, and I can show you there's several nutrient deficiencies that can cause neuropathy. So B12 isn't the only one. Okay, so the point is that we want to address that. Another nutrient that's been associated with neuropathy is alpha lipoic acid. And we also know that alpha lipoic acid sensitizes the insulin receptors. So once again, this is something that we look at. So you can see here in these bullets that we have seen both sensory and motor deficits associated with the diabetic, and I've seen benefit of both of them, once again, through this particular product. Okay, so the point is that there's two nutrients right now we talked about magnesium, or three nutrients, I should say, alpha lipoic acid and CoQ10. Now vitamin D. We all know how common vitamin D deficiency is. In fact, I was lecturing a couple weeks ago in Wisconsin, and I was showing this, that they say that 90% of the world population has an insignificant or mild to moderate deficiency of vitamin D, okay? So of course, when people talk about vitamin D deficiency, they say you have less than 20 nanograms per milliliter. If you have 20 to 30, okay, it's once again so-called borderline or insufficient, okay? Once again, we're talking about 90% of those people have a vitamin D level of less than 30. Now think about this, okay, and you can see here, we know that we can make vitamin D from this schematic here. It shows you that and how important, of course, in the conversion is, goes from the skin to the liver to the kidney. So once again, if we have kidney malfunction or damage, once again, we ultimately can have vitamin D deficiency. Now, the importance of this is magnesium plays a role in this. So each time we convert from the liver to the kidney, so we do the hydroxylation, magnesium is required. So now we have a strong connection between magnesium and vitamin D. Okay, so the next thing is, once again, as we're looking at this, this just tells you the different levels as far as severe deficiency, deficiency, insufficiency, and so on. And like I was saying, if you look at the middle part of that, where it says insufficiency, where it's 20 to 30, 90% of the world population has that level. Okay. So the thing is, that helps the connection to vitamin D and diabetes. Well, once again, insulin production, insulin secretion, and insulin receptors. So once again, and vitamin D is very interesting that vitamin D deficiency not only can be caused by, of course, lack of intake, but also can be caused by medication. A lot of people don't know this, but statins also can cause vitamin D deficiency. Okay, so this is something we look at. And once again, going on to the benefit or the function of vitamin D and how it can result in diabetic production, or I should say development. Okay. So the thing is, what do we do about this? And this is just a more advanced indication of how some researchers out there have found some mechanisms associated with vitamin D and diabetes, and they've got down to the cellular level where it has a huge impact. Okay. Now, isn't it interesting that when we talk about vitamin D deficiency, or I should say diabetes and vitamin D deficiency, we often talk about Hispanics and African Americans having the highest incidence of diabetes and high blood pressure. Well, isn't it also interesting that those ethnicities also have one of the highest incidence of vitamin D deficiency? So as we know, as you can see here, vitamin D deficiency doesn't just relate to diabetes, but it also relates to comorbidities associated with diabetes, the retinopathy, the neuropathies, and nephropathies. Okay, so when we're looking at these, it's very important. Another nutrient, zinc. Zinc deficiency is very common, especially in people that are vegans or semi-vegetarians. Once again, a lot of those people say, well, they can get their zinc from plant foods, and they can, but they have to consume a lot of it to do that. But you can see here that in this particular notation, about 50% of people only consume about 75% of this particular recommended daily allowance as far as this mineral. Okay, so the next thing is, well, what's zinc and diabetes? How does that correlate? Okay, so when we look at that, zinc helps with insulin synthesis, it helps with insulin secretion, and now there's of course correlation that zinc may also come into play with the receptor sensitivity. So here's a connection with one mineral, just like magnesium, and the vitamin like vitamin D, and then of course a metabolite like CoQ10 that comes into play. Okay, so the thing is that if you are examining patients, and this is something that you may see when you're doing the exam, and you see those white lines or white spots on their nails, once again, that's called leukonychia. That's highly associated with zinc. So right away, that should tell you that if a diabetic has that they probably have had or presently have a zinc deficiency, and you can improve their sensitivity on their receptors and the production if they're type 2 as far as insulin by helping them with zinc. Okay, so chromium is probably one of the more common ones that people talk about when you say, I want to balance out my blood sugar, or I have a craving for sweets, you know, how can I solve that? Once again, this is usually a mineral that everybody talks about. And once again, these are some of the mechanisms that chromium is associated with. Okay, so when we were looking at that, we find that once again, when I talked about a type 1 diabetic, and I said, well, can you have a role with micronutrients with a type 1, even though the pancreatic function is not there anymore as far as insulin production? Well, yes, you can, because you can see here that chromium is involved with insulin receptors. So depending on how much insulin that person requires may be changed by taking chromium, by actually affecting the receptors. Okay, so the point is that, once again, we have a role to play, whether it's type 1 or type 2 diabetics, from a micronutrient standpoint. All right, so when we are looking at that, once again, something that comes into play with these particular individuals is, of course, we always look at A1C, right? Well, you can see here that we've seen decreased levels, and I see it happen in my office all the time. When a person is deficient in chromium, we give them chromium, all of a sudden their A1C levels go from 8 to 7 to under 6, and of course, often into normal level. Okay, next. So the point is that we have a huge impact, but the other thing I want to emphasize, as it shows here, is it also affects your lipids. So the cholesterol levels can be decreased with chromium, but the other thing I want to emphasize, it's not going to happen overnight. As it states here, it may take 6 to 12 weeks or longer for you to really benefit that diabetic, whether it's type 1 or type 2 diabetic. So don't expect if a patient says, well, when can I expect my A1Cs to get better? Or when can I expect my glucose levels to get better? When can I expect my cholesterol to get low? Well, if you tell them 2 to 3 weeks after giving them chromium, they're going to be very unhappy because it's not going to happen in 2 to 3 weeks. So make sure you give them adequate time. So I usually tell all my patients, whether it's magnesium, chromium, zinc, or whatever, we're looking at a minimum of 4 to 6 months before we see a substantial change in your biochemistry. Okay, so the point is, let's talk about some other medication. We talked about antihypertensive medication. I mentioned briefly about statins. Here's metformin. Metformin, we know, and this is well-documented literature, that metformin can cause B12 and or folate deficiencies. Well, what's interesting about this, as we know, both of these vitamins can also cause neuropathy, right? We know B12 and folate deficiencies can also cause memory loss. We also know that, once again, these particular deficiencies are common with other ailments, whether it's liver dysfunction, whether it's kidney dysfunction, or whatever. So the point is, here we're getting a medication that's helping regulate our glucose, but it's causing 1 or 2 of these deficiencies that are causing the comorbidities that we're talking about. Okay, so as we look at these, once again, we have to realize that this is important. Now, let's take it a little further. Let's take these individuals that now they're pregnant, these women are pregnant, and they've developed gestational diabetes. And maybe the OBGYN says, oh, we need to put you on metformin because if you have gestational diabetes, of course, you can have a larger baby, you can have these complications associated with it. Well, what about the effect that has on the fetus? Because now if they're taking metformin and they're causing a folate or B12 deficiency, is that going to cause abnormal growth and development of that child? Or is it even going to cause a miscarriage or anything like that? So this is something we have to look at. Okay, next. So even though women, when they're pregnant, they definitely are going to probably be on a prenatal, which has the folate in it, but does it have enough B12 in it? And most of them do not have enough B12, especially if they go on metformin. So here's a great study, and they showed some schematics and some mechanisms associated with B12 and folate deficiency. And this, you can see, was published last year in June. Okay, so the thing that we're looking at is, how do we determine if someone has a deficiency? We can't just assume that they have a deficiency. Yes, we talked about statins and CoQ10. I talked about antihypertensive and magnesium deficiency. We talked about metformin and B12 and folate deficiencies. The only way we know, just like monitoring a diabetic, is to monitor their A1C, to monitor to see if a diabetic's going into renal failure, of course, the GFR, the creatinine, the cystatin C, and so on. The same thing is true with cell science and looking at these nutrients. You can see that we look at several nutrients from intracellular level, and we determine which ones are there. And then if we supplement with these micronutrients, do we have the right dosage? Once again, we do follow-ups, and that's what we look at. Now, this particular test, the CMA, looks back 6 to 9 months. So once again, when you do this test, and this is what I was saying, that if you supplement somebody, you need to supplement them for at least 6 to 9 months to see a biochemical change. And we're looking at the lymphocyte. We're looking from an intracellular standpoint versus a serum or plasma standpoint. And you can see here, CoQ10 is mentioned here, zinc's mentioned here, chromium is mentioned here, magnesium is mentioned here. So the nutrients that we talked about tonight, even though there's more nutrients involved with diabetes and those I mentioned, those are very common ones, is they're monitored and they're looked at in this particular test. Okay, so the point is that those individual nutrients are very important. However, as I mentioned, another factor that comes into play with diabetes and other pathologies is inflammation or oxidative stress. And this portion of the testing from Cell Science is what we call the antioxidant protection assay, of the APA. And you can see here, this particular testing is not a deficiency of these. This particular testing, this part of the test, is telling you what's protective of the cell to prevent an excess oxidative stress on the patient or excess inflammation. And so from an individual standpoint, for example, a person may do this testing and you can see here where it says they're protective or highly protective, meaning that it has a decreased oxidative stress on the individual cells if they take a particular herbal product or vitamin or metabolic product on this particular listing. So this would complement the nutrients that would be deficient on the CMA. Okay, so once again, this is very important to look at. And you can see the so-called oxidative stress that you're looking at is listed here as a redox assay. And you can see if you're below average or if you're normal, if you're above average, it's noted with this little diamond, depending on what part of the colored graph is involved. And once again, you would particularly look at that. And it's all individual. For example, when I did this test of myself, zinc was very protective, milk thistle was very protective of me, elderberry was very protective of me. So I know that if I want to decrease my oxidative stress, in addition to some other products that I may take, those are products that are very unique to me and I need to consume to have that decreased oxidative stress. Okay, so there's a company that's is involved with Cell Sciences. It's called Vitamin Lab, that when you get the report from the CMA, this particular company has a customized formulation that can be produced for that patient's deficiencies. And you can see that the numbers are listed here as far as the milligrams, micrograms. You also have the capability of modifying those dosages as a clinician. So if you feel that in this particular case, they have L-serine at 255 milligrams, if you want to say, no, I think I need to go 400, you can change that and they can specifically make that customized formula for that patient based off the CMA, which is very unique for that individual. And once again, that person would follow this particular regimen for at least 6 to 9 months before we retested that individual to see if we had the adequate dosages. Okay. So once again, you can see that a lot of people, of course, when they have conditions, whether it's blood pressure, cholesterol, diabetes, they may be taking a lot of, supplementation, or could be taking a lot of supplementation rather than a customized formula that could put it into one particular bottle and then noted based on the dosages of the nutrients would provide that to the patient. And you can see once again, there's an increased compliance when this is done. And so it's something that you definitely have the capability of providing to your patients based off the CMA. It's all based off the CMA, okay? So once again, this is something that I think is very important. And as Robert mentioned earlier, that Previmedica is also a company associated with Cell Sciences, which has individual counseling that can be performed based on these findings, whether it's allergy testing, the LCAT testing, whether it's the CMA or some of the other diagnostics that Cell Science has to offer. And I think it's an excellent program. They're very detailed.
Dr. Grabowski, can I interrupt?
Absolutely.
All right, thank you so much for that amazing, wonderful presentation. We really, really appreciate your expertise. Hi, everyone. I'm Amy Pozarka, and I'm the Director of Nutrition for Previmedica. And just to, as Dr. Grabowski said, we are the sister company to Cell Science Systems, And we're a team of nutritionists. I'm overseeing an awesome team of nutritionists, and we're providing individualized guidance to patients to meet their unique needs. And how this is just kind of a little summary about how we can help you help your patients. First of all, for any of the tests that Cell Science Systems offers, there is the opportunity to meet with one of us to review the test results. And this is complimentary. It's a complimentary review. It's a half hour per test that would be for you as a practitioner or your patient, or for both of you together. And Dr. Grabowski, thankfully, is also able to meet with practitioners to discuss the CNA, also the methyl detox profile that Cell Science Systems offers, and the telomere test. As you know, your patients need tools to put your nutrition plan into action and to actually stick with it. So we offer a customized meal planning service to help your patients in their day-to-day choices. If you're using the ALCAT test for food and chemical sensitivities, those meal planning tools will be generated using those test results. And if desired, we can include your brand, your logo on that booklet rather than Previmedica's, so that this booklet is actually coming from you. And I know the nutritionists in the audience definitely know how time-consuming making tools like those can be. So that would be a real time saver for you, and of course, a big help to your patients. And then the other way we can help you and your patients is through providing nutrition and lifestyle guidance. The nutritionists in the audience, of course, would not need this from us, but for practitioners who do not have a nutritionist on their team, but need someone to fulfill that role, we can do that. So we do, of course, individualize all of our guidance, and the patients, we see people in 1-month memberships. There are 2 sessions included in that 1 month with a nutritionist, and there's one nutritionist assigned to the patient, so that, for continuity. A personalized nutrition plan is provided. That includes meal planning tools, as I mentioned previously, menu ideas, and an individualized supplement routine. And for the supplement routine, if you prefer, we would use the supplement platform that you prefer using your account, like the Vitamin Lab, like Dr. Grabowski described, or Wellevate, FullScript, whatever the case may be. And then, of course, access to our educational resources, daily support from the patient's nutritionist, and you as the practitioner would be included on the Previmedica patient practitioner portal, so that you can see all of the nutritionist documentation for each of your patients, and also the resources that we provide to each patient. So, if you'd like to find out more about that, how that relationship could help you, you'll see the contact information later on, but also you can feel free to email us at hello@previmedica.com. So thanks very much for listening to that. And Robert, I think you wanted to say a few things about this.
Yeah, thank you, Amy. Thank you for that great overview there of Previmedica. And thank you, Dr. Grabowski. Great presentation, very detailed. You can see we're kind of scrambling, trying to meet that hour that we told everybody we'd take their time. We appreciate you hanging on. We do have some questions. Here's our contact information page. And of course, our next webinar by Dr. Grabowski, what ties in nicely with what we did tonight, the nutritional deficiencies associated with cardiovascular disease. So nice tying in those two together. Hope you can make it the next time. Let's go through those questions, Amy. I think you can probably read those better than mine. Go ahead.
Dr. Grabowski, we're getting a question about what form of magnesium do you recommend? Is magnesium bisglycinate better absorbed?
Yes, bisglycinate is definitely better absorbed, and there's actually a great textbook out there for those of you that are interested. It's a very detailed textbook. It's called Amino Acid Chelation in Human and Animal Studies. It's by CRC Press. It was published in 2012, but it goes into great detail on different forms of minerals and why we use different forms of minerals for absorption. And once again, that's the big thing. It's not just giving a mineral like magnesium or giving a product like CoQ10, but it's given the right dosage in the right form. And I have a lot of people that come into my office, just like you all do, where a patient comes and says, oh, yeah, I'm taking magnesium, and it doesn't help my blood pressure, it hasn't helped my diabetes, whatever, and it might be magnesium carbonate or might be magnesium oxide. Well, those are very poorly absorbed forms. So just because someone's taken it doesn't mean it's going to work. And once again, you want objective data like the testing, the CMA that I mentioned, to really determine if it's working.
Mhm. Thank you. All right, so, a question, how can we get your presentation on neuropathy?
I can give it to Robert, I can give it to you, Amy, and we can, I can send that
Well,
out.
we could definitely make that one of our monthly webinars for sure.
Yeah.
It's a yeah, we could definitely do
Yeah,
that. So stay tuned. You'll see that coming up soon.
Yeah,
All right.
and I can tell you this about the cardiovascular lecture that's coming up. I'm going to surprise you with a lot of information out there on new nutrients or nutrients that you wouldn't maybe even recognize or realize that play a huge role with cardiovascular disease. A lot of people, of course, talk about the omega-3s, and that's very important, and niacin and things like that. But we're going to talk about some nutrients and show you some new interesting data regarding micronutrients and how they affect our cardiovascular system.
Awesome. Okay, for patients who have diabetes and also kidney disease, what would be the suggestion for magnesium, as magnesium levels usually are high in kidney disease patients? Would topical magnesium be helpful or detrimental in kidney disease patients?
Well, whether you use topical, I mean, if you use topical and it gets into the system, it's still, a lot of magnesium is excreted in through the kidneys and also excreted in the digestive tract. So you're still going to get it in the system, whether it's topical or oral, or even if you did, injections or IV or anything like that. So the point is, how severe is the kidney condition? I mean, if you're at end-stage renal disease, you have to watch it very closely. And once again, as I mentioned, when I was a dialysis dietitian, these are things that we've monitored. But hopefully you can get it to the point where the person is in end-stage renal disease and they still have enough kidney function where if they do have excess magnesium, it can be excreted through the kidneys.
Okay. CoQ10 supplements absorb well. Any particular brand that you would recommend, or are we comparing apples to apples? If they need it, they simply need to take it.
No, definitely. I can tell you from clinical experience as well as the literature, we definitely look more at the ubiquinol. We are now finding out that, in the process of making CoQ10, some of that product actually crystallizes. And there is information out there showing that when citrus products are introduced into the manufacturing of CoQ10, that it helps prevent crystallization of the CoQ10. So it's actually, you get a better percentage. There's companies out there, there's a company called Nutritional that actually has a crystal-free ubiquinol. And once again, it goes through that process. And this is noted in independent literature. So CoQ10 compared to another CoQ10, they're not apples to apples. There's definitely a difference, and there's a better bioavailability with these particular types. But definitely I would go more ubiquinol than ubiquinone.
Okay. And someone had requested that I put the name of the book in the chat. I just did that, so everyone should be able to see that. And one last question I see, can you please, maybe this would be for another time, but can you please discuss reasons nutrient deficiencies are associated with hemolytic anemia besides fatty acids?
Okay, so any nutrient that has an effect as an antioxidant is going to protect the cell membranes and help with hemolytic anemia. A lot of people, when they looked at hemolytic anemia, of course, they looked at vitamin E initially because, of course, being a nice antioxidant. Then, of course, they looked at essential fatty acids, of course, because of the cell membranes. But anything that can protect those lipids, whether it's phospholipids, omega-3s, omega-6s, omega-9s of the cell membrane from being oxidized, is going to help with hemolytic anemia. So those are the things you have to look at. But because of literature in the past, we've always looked at vitamin E as being protective or essential fatty acids being protective. But think of this: anything that can have antioxidant capabilities and protect against lipid peroxidation of the cell membrane is going to be beneficial. So you're looking at a lot of nutrients that have antioxidant function.
Wonderful. All right. I think that does it. That's it for the questions. And just to remind everybody, the recording will be sent out probably by the end of the day tomorrow. Hopefully everyone saw the slides that were included. Dr. Grabowski's slides are here as well under the handout section.
Great.
Robert,
Thank you so much, everybody. We appreciate it. We went over time. We appreciate you sticking with us, and we hope you come back to our next webinar next month. Be around the same time. You'll get an email, of course. Thank you, Dr. Grabowski, for taking time to put this together. Very detailed information, very beneficial for all you clinicians out there who are seeing diabetics. So we'll let everybody go. Have a great night. We'll see you on the next one.
thank you, everybody. Thank you, Dr. Grabowski.
All right, thank you.